Hi everyone, my name is Brennan Matoyu. I'm a fourth year UBC medical student, class of 2021, and today's lecture will be on carpal tunnel syndrome. The outline for today's lecture will include a brief introduction. We will discuss the risk factors and associations, pertinent anatomy, pathology, clinical presentation, and finally treatment options. Carpal tunnel syndrome is the most common upper extremity compression neuropathy. It is caused by compression of the median nerve at the wrist as it passes through a space-limited osteofibrous canal. This can result in paresthesia or numbness on the radial distribution of the hand, and in long-standing cases, hand weakness and atrophy of the thenar musculature. Its prevalence is reported as high as 3.72% in the general population. The median nerve enters the forearm medial to the brachial artery at the elbow. It splits the head of the pronator teres and travels down the forearm between FDS and FDP. Before it enters the carpal tunnel, it lies superficially between the tendons of the flexor carpi radialis and palmaris longus muscles and gives off the palmar cutaneous branch 5 centimeters proximal to the carpal tunnel. The median nerve then travels into the carpal tunnel deep to the flexor retinaculum. At the end of the carpal tunnel, the median nerve will give off the motor recurrent branch to supply abductor pollicis brevis, opponens pollicis, and the superficial head of flexor pollicis brevis, as well as 2 radial lumbricals. The proper digital nerves also will provide innervation to the palmar surface of the thumb, index, middle, and radial half of the ring finger. The roof of the carpal tunnel is the flexor retinaculum, also known as the transverse carpal ligament. It spans from the hamate and tricretrum ulnarly to the scaphoid and trapezium radially. Within the carpal tunnel, there's 9 tendons, FDP, FDS, and the FPL, as well as the median nerve. FCU, FCR, and palmaris longus are not contained within the carpal tunnel. As previously mentioned, the recurrent motor branches typically branch just distal to the carpal tunnel. However, there are various branching patterns that have been described in literature and are important to be aware of, particularly during surgical decompression. We will not cover those in this lecture. The median nerve neuropathy that occurs is due to nerve entrapment, which is simply a disproportion between volume of nerve and the space through which it passes. This disproportion puts elevated extraneural pressure onto the nerve, which in turn causes inhibition of intraneural microvascular blood flow. As a result, nerve ischemia and decreased axonal transport occurs. Ultimately, this results in demyelination and distal axonal degeneration. The degree to which axonal injury occurs is proportional to both the magnitude and duration of compression onto the nerve. Clinically, patients may report intermittent to constant paresthesia in the median nerve distribution, the thumb, index finger, middle finger, and radial side of the ring finger. The thenar eminence is often spared as the palmar cutaneous branch branches prior to the carpal tunnel. Additional symptoms include pain worse at night, decreased dexterity, weakness and atrophy of the thenar musculature as late symptoms, and motor function becoming increasingly impaired. On physical examination, motor function can be assessed by any weakness of thenar musculature, including thumb opposition or power pinch. Late carpal tunnel syndrome will present with thenar eminence atrophy. Sensibility can be superficially examined by light touch in the median nerve distribution using a 10-point scale to monitor progress. Threshold testing can be done using Sims-Weinstein monofilament. Innervation density can be done using 2-point discrimination. Provocative tests include Phelan's, Tennell's, and Durkin's test seen in the image. The exact cause of carpal tunnel syndrome is largely unknown and a multifactorial origin is assumed. Most of these cases are considered to be idiopathic, with inflamed synovium being the most common cause of idiopathic carpal tunnel syndrome. There are some risk factors that may predispose patients to carpal tunnel syndrome. Anatomic causes include trauma, i.e. distal radius fractures and carpal dislocations resulting in acute carpal tunnel syndrome, or masses in the carpal tunnel that may cause extrinsic pressure on the nerve. Numerous conditions have been associated as suspected risk factors, including rheumatoid arthritis, gout, diabetes, hypothyroidism, pregnancy, obesity, and menopause. The association between occupational factors and carpal tunnel syndrome is still extremely controversial. Carpal tunnel syndrome is a clinical diagnosis based on a combination of symptoms and physical exam findings. However, both nerve conduction studies and electromyography can also be used to stage the degree of nerve compression. Nerve compression studies are used to demonstrate segmental demyelination representing nerve conduction blocks. It allows you to measure how well and how fast a nerve can send electrical signals. Motor latency is greater than 4.5 milliseconds, and sensory latency is greater than 3.5 milliseconds are characteristics of carpal tunnel syndrome. Electromyography can also be used to assess resting muscle activity and activity upon needle insertion, which may indicate early denervation or chronic muscle degeneration. It's also helpful to use during recovery to show reinnervation after carpal tunnel release. Many non-surgical options initially exist for patients with carpal tunnel syndrome. Postural and activity modification, nocturnal wrist splinting in a neutral position are often first-line conservative options. NSAIDs can be helpful to manage the pain control associated with carpal tunnel, however, provides no benefit in preventing progression of the disease. Finally, steroid injections can be considered as an option for mild symptoms if other treatments are unsuccessful. Operative treatment involves complete division of the transverse carpal ligament. There are two surgical options, including open release of the transverse carpal ligament or endoscopic carpal tunnel release. Both demonstrate comparable results, with literature reporting faster rehab with endoscopic release. Complications include incomplete division of the transverse carpal ligament, damage to the palmar cutaneous branch, and a painful hypertrophic scar afterwards. In summary, carpal tunnel syndrome is a compressive mononeuropathy of the median nerve at the wrist. It can result in paresthesia or numbness in the radial distribution of the hand, and in long-standing cases can cause hand weakness and atrophy of the thenar musculature. The carpal tunnel consists of 9 flexor tendons and the median nerve. It is a clinical diagnosis that can be confirmed by electrodiagnostic studies. Many non-operative options exist, and operative management options include open carpal tunnel release or endoscopic carpal tunnel release.